Hi, everyone. My name is Elizabeth. I'm a registered dietitian and a certified nutrition support clinician. I work at Rush Medical Center in Chicago, and today I'm excited to talk to you about managing a patient on parenteral nutrition who has a history of type 2 diabetes. Let's quickly touch on why it's important to manage hyperglycemia. And really, it comes down to seeing an increase in morbidity and mortality with hyperglycemia. We see an increased risk of infection, sepsis, poor wound healing, and other issues that come about when a patient is experiencing uncontrolled blood sugar. Additionally, hyperglycemia can lead to an increase in length of stay as well. So when parenteral nutrition was first being utilized in like the 60s, 70s, there were no or limited IV lipid emulsions, and therefore a significant amount of calories were coming from dextrose. Additionally, there was the thought back then that like the more nutrition, the better. And so patients were dosed with a really high calorie per kilogram ranges, which led to high amounts of dextrose in parenteral nutrition. And this led to issues with hyperglycemia, infection, and liver issues. But now we have some really great recommendations from Aspen, some guidelines on how to appropriately dose our patients for dextrose, amino acids, lipids. We have better lipid emulsions now, so we can kind of come down on the calories from dextrose and come up on the calories from lipids. And we can make sure that we're feeding our patients appropriately in terms of dextrose, amino acids, and fat. So let's run through a case study together that kind of highlights how we can manage blood sugar while providing PN, and also how we approach adding insulin to our parenteral nutrition order as well. So for this case study, I had a patient, a 55-year-old male. He had a past medical history of heart failure, type 2 diabetes, obstructive sleep apnea, and hypertension. And he presented with acute onset lower abdominal pain. So to kind of run you through his initial hospital course, on day one, he gets a CT of his abdomen and pelvis, and it shows signs of small bowel obstruction. He's taken to the OR for an exploratory laparotomy and then had a small bowel resection. His bowels were actually left in discontinuity, and his abdomen was left open. On day two, he returned to the OR for another XLAP. He had an ileostomy created, and then his abdomen was closed. On day three, the patient was extubated. And then on day four, the nutrition support team was consulted because the surgical team was worried that it was going to take a long time for his return of bowel function. And so they placed a central line and they asked us to start parenteral nutrition for this patient. So kind of looking through his anthropometrics, we can see that he has a weight of 80.5 kilograms. His BMI is around 27. When I went to assess this patient, I found out he typically manages his type 2 diabetes through following a consistent carbohydrate diet. He had no changes to his appetite or how much food he was eating prior to admission. He had no recent significant weight changes. His NSP was totally unremarkable and was not concerned for malnutrition at that time, except for that he had now gone about 4 to 5 days with minimal or no nutrition. So our first step with helping manage blood sugar is making sure we are appropriately dosing the macronutrients. So for this patient, I'm starting with his dosing weight of 80.5 kilograms. I know that he has an overweight BMI, so we want to dose within that 20 to 25 calorie per kilo range. I went with 20 calories per kilo for this patient, so providing him around 1610 calories from his parenteral nutrition. Because I'm going on the lower end of the calories, I want to make sure we're adequately providing protein. So I set him at 1.5 grams of protein per kilo, which comes out to around 121 grams of protein. Lastly, we want to make sure that we're including fat. He's appropriate to get 50 grams of an IV lipid emulsion daily, so about 500 calories from fat per day. Looking at our calories from protein and fat, we're going to need around 626 calories from dextrose. This comes out to 184 grams of dextrose. Now we want to make sure that this dextrose content is an appropriate amount. So we're going to calculate our dextrose infusion rate, which when we run through that calculation, we see that it provides 1.59 milligrams of dextrose per kilogram per minute, which is within that acceptable range of being less than 4 to 5 milligrams per kilogram per minute per our Aspen guidelines. Next up, we just determine our total volume of the bag, looking at their dextrose and amino acids, and we determine that we need a 1.7 liter volume bag. So in total, our goal final PN prescription for this patient is a 1.7 liter bag with 184 grams of dextrose, 121 grams of amino acids, and 250 mLs of the 20% IV lipid emulsion every 24 hours. So here's a list of the medications that the patient is on. Nothing's really standing out too much to me. And then looking at his labs for the day that we're starting parenteral nutrition, all of his electrolytes are within normal limits, which is great. We're not really worried about refeeding syndrome for this patient. But I do notice that he has that one blood sugar check of 181, which is above that acceptable range of 180 or less. And it was actually treated with 1 unit of regular insulin subcutaneously, which is what that 1 in parentheses represents. Okay, so for his first bag of parenteral nutrition, I do want to highlight that I'm starting at half goal dextrose. Since we want to make sure we start at a lower amount of dextrose first to help manage blood sugar, help prevent any refeeding, things like that. And then everything else, you'll see all the other components that were included in that bag. So the next day I come in and I look at his labs. Again, great, all of his electrolytes are within normal limits, but I noticed, kind of like we suspected was going to happen, his blood sugars are now elevated. You can see 181, 209, 190, 213. He's definitely got some elevated blood sugars, and keeping in mind right now, he's still at only half our goal dextrose amount. So I like to run through a checklist when looking at a patient with hyperglycemia that's on parenteral nutrition. I first want to make sure that the patient's not on any medications that could be contributing to his high blood sugars. I like to see if they're on fluids that contain dextrose, like D5W, for example, or if the patient's on steroids. That could also be contributing to high blood sugars, but this patient doesn't have any of that going on. Also considering if a patient is eating orally or is getting enteral nutrition, which this patient is strict NPO and is not getting enteral nutrition. So we know that the hyperglycemia can't be caused by an oral or enteral diet right now either. I also like to make sure that my PN formula is not overfeeding our patient, which we just ran through the macronutrients, and we know that we're definitely not overfeeding this patient at this time. Another kind of thing you can look at is if you can go up on the lipids to help provide more calories from fat, if it's appropriate to do so. But this patient's already getting daily lipids, so we can't really make any adjustments there. So after going through that checklist, I realized this patient's probably going to need to get some insulin added to their TPN, especially knowing he has a history of type 2 diabetes. But as things work out, I talked to the medical team that day, and they were hoping that the parenteral nutrition would just be temporary. So they wanted to manage the blood sugar outside of the TPN by giving subcutaneous insulin as needed throughout the day. So the second day of TPN, we decided to not put insulin in the bag, but we're keeping dextrose at half goal dextrose because we do not want to advance the dextrose amount if blood sugars are not controlled. So the following day came in and saw his labs. Again, electrolytes look great, wonderful, but his blood sugar is still not being adequately managed. We're now seeing 228, 260, 209. He's requiring higher amounts of subcutaneous insulin during the day. So now our medical team is on board with adding insulin to the TPN. So most institutions will have their own protocol for adding insulin to parenteral nutrition. It might be that you have pharmacists dosing the insulin. You could have members of the endocrinology team providing recommendations on how much insulin to add to the TPN, or it could also be dietitian driven. For my institution, we do have ordering privileges to add insulin to the TPN as long as it follows our outlined protocol. So here's an example of what an insulin dosing protocol might look like. For this patient, he has a known history of diabetes and he's been requiring insulin. So we're going to start with dosing insulin at 0.1 units of insulin per gram of dextrose in the PN solution. So for example, this patient, we're giving 92 grams of dextrose. So we're going to multiply that 92 grams of dextrose by 0.1 units of insulin per gram dextrose, which comes out to 9.2 units of insulin I'm, to be cautious, going to round down and provide 9 units of insulin in our parenteral nutrition. So here is the bag that I provided that patient that night, noticing I'm still doing half gold dextrose because we don't want to advance just yet until blood sugar looks better. And then I'm also adding in the 9 units of insulin. So the following day came in and I noticed his labs, his blood sugar is still high, but coming down a little bit as the day goes on, as that new bag is showing, with the new bag with the insulin is showing some effect on the blood sugar. Okay, so going back to our insulin protocol, if blood sugars are still elevated, even with that 0.1 units of insulin per gram dextrose ratio, we can start increasing in increments of 0.05 units per gram of dextrose until we're maintaining blood sugar in appropriate range. So we're going to take that 92 grams of dextrose, we're going to multiply it by 0.05 units of insulin per gram dextrose. This comes out to 4.6 units of insulin. So this next time, we're going to increase our insulin amount by 5 units of insulin. So we already have 9 units in the bag. We're going to add that additional correction amount of 5 units. So we're going to 14 units of regular insulin in our TPN bag tonight. So this is the bag that I wrote for the patient that night. You'll see I'm still at half gold dextrose because the blood sugars are not well managed yet, but we're increasing to the 14 units of insulin. So next day, we see that the insulin did have a good effect. We're seeing 182, 170, 165, 145. So we're definitely now within that goal range of 180 or less for blood sugar. Now, what do we do? Because we're still only at half gold dextrose, we want to advance since blood sugar is better controlled. What we can do is keep the insulin amount in the same ratio. So for right now, we have 14 units of insulin for 92 grams of dextrose. This is providing 0.15 units of insulin per gram of dextrose. We can double that insulin amount, and we'll see that that way it will be in the same ratio as what we're providing right now. So if we increase to 184 grams of dextrose, we're going to increase our insulin from 14 units to 28 units, which when you do the math, 28 units of insulin per 184 grams of dextrose comes out to 0.15 units of insulin per gram of dextrose, which is the exact same ratio that we were providing when we were at half gold dextrose. So here you will see on day 5, I was able to advance to our gold dextrose amount, and I increased it to 28 units of insulin in our TPN bag. Okay, so I followed up with the patient the next day. Labs looked great, blood sugar looked great. He continued on this parenteral nutrition course for the next few days until eventually we were able to advance his diet. He's able to come off the parenteral nutrition and then continued on his course and eventually got discharged. All right, thank you so much for listening. I'll see you in the next one.